Hello everyone, this is John Mandrola from the Heart.org Medscape Cardiology, and this is This Week in Cardiology for March 9th, 2018. This week, obesity, type 2 diabetes, varicose veins and VTE, coronary artery bypass graft surgery, and an ACC preview. First up is obesity in young people. Whenever I hear or see reports that obesity rates are decreasing, I wonder if they come from fiction rather than non-fiction sources. Here in Middle America, where I am, the most scary thing about public health is that obesity is becoming normal. A report in a journal of Pediatrics confirms my suspicion. Obesity, at least in the young, is worsening. Researchers in this study used the NHANES database from 1999 to 2016 and reported on trends of obesity. And they found that white and Asian American children have significantly lower rates of obesity than African American or Hispanic children. They also found a positive linear trend for all definitions of overweight and obesity among children, most prominently in adults, and children aged 2 to 5 showed a sharp increase in obesity from 2015 to 2016. My gosh, friends, obesity is like this slow-rolling train. It's like a disaster. It doesn't get the attention of like a measles outbreaks, but mark my words, it's a looming public health disaster. We routinely see young and middle-aged adults that are dying of obesity. Literally, they're dying of being too fat. And hardly any of the caregivers now say much about it because it's just so common to see obese people. Next up, type 2 diabetes. This next study is a perfect one to follow the obesity report. This way you don't have to take my anecdotes on the dangers of obesity. This study, a population-based cohort study linking a national diabetes database to the National Death Index in Australia, asked the question about the impact of age of diagnosis of diabetes on all-cause and cause-specific mortality. The diabetes journal Diabetologia published the study of almost 750,000 people. Over a median follow-up of 7 years, the authors found that an earlier diagnosis of type 2 diabetes, or in other words, a longer duration having the disease, was associated with a higher risk of all-cause mortality, and this was primarily driven by CVD mortality. The effects were similar in men and women. A 10-year earlier diagnosis, or equivalent to a 10 years longer duration of having diabetes, was associated with a 1.2 to 1.3 times increased risk of all-cause mortality and about a 1.6 times increased risk of cardiovascular disease mortality. These are important observations because some studies have shown a decline in excess risk of death in people with diabetes. And that may be true if you take all comers, but this study, along with others cited in the paper, showed that a diagnosis at a younger age confers a greater risk. Now, to be sure, this is an observational study, and the authors lack info on potential covariates like ethnicity or smoking, glycemic controls, and physical activity. But since obesity is a risk factor for getting type 2 diabetes, you can see the connection between rising rates of obesity in the young and increased disease from diabetes down the road. Again, I propose that this is a looming public health disaster. Third topic is varicose veins and the risk of venous thromboembolism, or VTE, or DVT. My wife Stacy left out our JAMA open to this page for me to see. Yes, the AMA still sends us a print version of the JAMA. And yes, I've inherited some pretty gnarly varicose veins from my mom's side of the family. And old thinking has it that peripheral venous disease is only bad when clots form in the deep veins. Superficial veins aren't supposed to matter much. Well, a large database study from Taiwan suggests a connection between varicose veins in the periphery and more serious issues in the deep veins and also pulmonary embolism. Now, I think this paper is worth highlighting, but more as an example as how not to be fooled by observational studies. First, the findings. The authors looked at more than 200,000 patients in the Taiwan National Database and found people with varicose veins get 5-fold more DVT and PE than a control group. Sounds bad, right? Maybe we should be looking more closely at people with varicosities. Well, the absolute differences were only 5 in 1,000 for VTE. That's 0.5% difference. And for PE, it was 2 in 10,000. What's more, this study uses claims data and propensity matching, which of course is better than no matching, but is still imperfect. But perhaps the most limiting limitation is that in this study, 2 falsification endpoints were also associated with varicose veins. Now, when falsification endpoints are positive, that means that confounding variables were highly likely to be present. I am not sure why this study rose to the level of a leading medical journal. I think we need stronger evidence before we make any connections between bad superficial veins and problems with the deep veins. Fourth topic is on-pump versus off-pump coronary artery bypass surgery. We've debated the merits and outcomes of off-pump versus on-pump CABG for years, decades even. British and Australian authors have now published a meta-analysis of 6 studies with more than 8,100 patients. They published in JACC, and they were looking at long-term outcomes after the 2 types of surgeries. Mortality was 12.3% in the on-pump group versus 13.9% in the off-pump group, and the odds ratio here was 1.16, and the p-value was 0.03. So definitely statistically significant advantage for on-pump surgery. The authors also looked at MI, angina, need for redo revascularization, and stroke, and found no statistical differences. The editorialists say it's time to move on from this debate. No RCT has shown off-pump surgery is better. They say the debate now needs reframing to figure out which patients may benefit more from either approach. And in their editorial, they gave examples of patients that may be better with off-pump surgery, say, for instance, someone with severe COPD. The editorials also spent great time outlining the increasing safety record of CABG on pump over the past 10 years. This fact, combined with the need for great technical expertise from the surgeon who's doing the off-pump surgery, argues strongly for favoring the on-pump strategy. Finally, the last topic is an ACC preview. The 2018 ACC meeting starts Saturday in Orlando. The lead late-breaking clinical trial will be the Odyssey Outcomes trial, which pits alirocumab versus placebo in patients who've had previous MI, so secondary prevention. This is a huge deal. These PCSK9 inhibitor drugs have dramatic lowering effects on LDL. In Fourier, the other PCSK9 inhibitor trial, evolocumab, reduced non-fatal events but did not reduce overall mortality. Odyssey is a longer trial, and it has a targeted LDL below 50, and those 2 factors may make it more likely to be more significantly positive than the Fourier trial. However, if Odyssey comes out about the same as Fourier, that means non-fatal reductions only, the PCSK9 inhibitors will likely not become mainstream drugs. If, on the other hand, alirocumab reduces mortality, this may certainly boost the status of these drugs. We will also hear results of the VEST trial. Now, this is an RCT comparing sudden death rates with or without the wearable cardiac defibrillator in high-risk patients 3 months after acute MI. This is an important trial. The LIFE-VEST has been out for over a decade, and there has not been any randomized controlled data so far, so this is the first. I'm also looking forward to late breakers on HIS bundle pacing, mobile health, personalized medicine, and many others. Both journalist Steve Stiles and I have written ACC preview columns, and they're up on the site now. Next week, during This Week in Cardiology, will be a recap of many of the important studies at ACC. Once again, I'm grateful that you listened. Thank you. This is John Mandrola from the Heart.org Medscape Cardiology.